Sally, thank you for this kind introduction, and also Professor Mufti for inviting me today for this very informative meeting. And I'm very honored to give the memorial lecture dedicated to Terry Hamlin. And maybe the lights can a little bit shut down, otherwise maybe the flow is not so good readable. So it was already introduced that Terry Hamlin was a great scientist and clinical hematologist. And this is a picture I get on the internet quite easily from the UK MDS forum. And most particularly his work was dedicated to CLL and not particularly MDS alone. And he also worked very close together with Professor Mufti at King's as a consultant hematologist. And I remember him from several meetings, not personally, but personally on the way that I sent several manuscripts to leukemia research in my beginning of my career, and with most of the time good responses. So I was lucky for that. And when I put into the PubMed and looked to his MDS career, he was mainly focused on the incidence of MDS, but also a lot of work on anemia and supportive care of the patients, also regarding transfusions. He worked on prognostic models, and in the end also on immunology. And when I came up with the first publication, it was together with his fellow Mufti in those days. And in just that time, I started my medical career, so 1982. And this last what I could find was on, together with his friends John Bennett and also with Ghulam, on the foundation and how this evolving field was done in an educational point of view in the MDS Foundation. So, going to MDS, it was already noted this morning, it is a heterogeneous disease. It is in the name, myelodysplastic syndromes. And it is heterogeneous on the microscope. It's also heterogeneous by doing flow cytometry, and I will educate you a little bit in that field. It's heterogeneous in cytogenetics and in molecular biology, and at the end, heterogeneous in the clinical course. So what we need to identify specific subgroup of patients with might be implicated for our clinical decision making, we should make homogeneous diseases. And therefore, I think it is very well known that we have to emphasize on diagnostics. And we are all aware of the diagnostics at the moment in MDS. So still, the peripheral blood smear is of importance, not only for the cytopenias, but also for the amount of dysplasia. That's essential, and to enumerate the blasts. And then the bone marrow aspirate is still very important for the same reason, to look into the amount of blasts and to account for dysplasia, because that is the hallmark of MDS. And then the bone marrow biopsy, not only looking to hypocellular marrows, looking to fibrosis, but also to mainly this megakaryopoiesis. And then cytogenetics came in, important not only for specific abnormalities, but also for prognostication. And if there's not a metaphase spread, you should go with some specific probes for FISH analysis. But then flow cytometry came in already some years ago, and it is a recommended tool, and it is recommended if performed according to specific criteria and specific standardization protocols, which were developed within the European Leukemia Net some years ago and will continuously be updated. And it is already a recommended tool, as well as mutations in those days were a suggested tool to support the diagnosis of MDS. And now we know that specific mutations like SLTP1 is related to or highly associated with the presence of ring sideroblasts. And the hallmark is still the microscope. And I think it still costs some years to replace the microscope as a standard for MDS to the standard by flow cytometry, because it is still not easy to account under the microscope all these specific characteristics of this erythropoiesis, and then also to count that at least 10% of the cells should have one of these specific abnormalities. So well-trained cytologists and hematologists can only do this job. And the same holds true for this granular poiesis and this megakaryopoiesis. Not easy, but still the hallmark of the diagnosis of MDS. So, if you look now to the WHO classification, still there are, regarding the morphology, no changes in defining dysplasia. Still, based on those microscopic criteria, 10% of the cells should be dysplastics. And still, the blood cell count is by microscopy and not by flow cytometry. And it is quite clear because the flow cytometry does measure totally different aspects of immature progenitor cells. But also it was pushed forward in the WHO classification that the blast count is of importance because of the translation to the prognostic system, the revised IPSS, because there is a prognostic power below 2%, between 2 and 5 and over 5% of blast. But regarding flow cytometry, it is stated, and it will be in the book very soon, in suspected MDS, if performed according to the recommended panel, it might add significantly to support the diagnosis or even to exclude the diagnosis of MDS. But now, what is the concept of flow cytometry? If you look under the microscope to the blasts, and then to the more maturing cells up to the most mature cells, and you look on the y-axis to the expression levels of differentiation antigens, and here on the x-axis to the differentiation pattern. It is now well known that, for instance, the differentiation marker CD13 is very low expressed on the most immature stages of the hematopoiesis in a normal situation. And upon differentiation to the promyelocytic stage, it is very highly upregulated, and it is very strongly regulated in normal hematopoiesis. There's really a connection between genetics, differentiation, and the phenotype. And then after the promyelocytic stage, it's rapidly downregulated to almost zero. It's off the cell. And then upon maturation, it's again upregulating up to the same level as it was on the early promyelocytic stage. And 11B, for instance, a maturation marker, is not expressed on the most immature forms, but after the promyelocytic stage, it became expressed up to this level in the most mature stages. And also CD16 is regulated very tightly in normal hematopoiesis, not expressed on early myeloid progenitor cells, but after a specific stage, it is upregulated. Tightly, always the same. And here you see a specific plot, CD13 versus CD16, and then you see an intermediate level in the early forms. Upon differentiation, it is highly upregulated. When CD16 comes, then CD13 is downregulated, and then it is again up. Always the same, and this is a so-called Nike stripe. The pattern is in every normal bone marrow the same. And if you then go with a lot of more antigens, you can imagine that all those differentiation markers are highly regulated. And then you can make models based on statistics. What is the difference of normal? For instance, the CD34, you know, here in blue, it's only highly expressed on the early progenitor cells, then it is downregulated very steeply. And if CD34 is still on the promyelocyte or even on the myelocytic stage, it's aberrant. But the same holds true if CD11B is expressed on the immature cells, it's aberrant. And not only the position in the differentiation process, but also the level of a specific antigen is aberrant in cases of MDS. So you can make models out of this normal configuration. But also looking to the monocytic differentiation patterns, you can do the same. CD34 is rapidly downregulated upon maturation, and then markers such as CD14 is coming in a little bit later, and also all these markers are really regulated very tightly based on genetic down of upregulation. So here a typical example, CD11B and HLA-DR. Here you see the very early CD11B negative cells with already HLA-DR, the early monocytic compartment, and then upon differentiation the cells come up from this side on HLA-DR, a little bit dim expression on the most mature cells, but 11B is coming in. So these are really regulated systems. And the last compartment in this respect are the red blood cell development, and these are early data now because the differentiation of the red blood cells are not so easy, but you can make the same patterns. For instance, focusing on the transferrin receptor, CD71, it is not expressed on the very early progenitor cells within the red blood cell development, and is highly upregulated, and then in most mature cells is a little bit down. And to look into this graph versus glycoprin A expression and the transferrin receptor, this is the differentiation pattern. So that means that in normal hematopoiesis, all these antigens are tightly regulated, either in the monocytic, the granulocytic, or the red blood cell compartment. So within the European Leukemia Net, we thought which antigens are most important to study normal versus abnormal hematopoiesis. And then we dissected this in the immature compartment, the so-called blasts by the microscope, but don't forget, blasts by the microscopes are not myeloprogenitor cells by flow. And then we came up with several recommended antigens, and here the appearances are notified. So don't read it in detail, but it is mainly based on the expression level and the early or late expression of normal antigens. But also the lineage infidelity expression. That means if you have CD7 or CD5, which is normally expressed only on lymphoid cells, can be expressed on myeloprogenitor cells, and it's aberrant. The same holds true for MRD and leukemia. That makes sense that, for instance, the aberrant expression on leukemic stem cells, for instance, the co-expression of lymphoid infidelity markers, is aberrant. The same holds true for MDS. Then we also looked into the maturing neutrophils, the maturing monocytes, as well as in the progenitor B-cell compartment and the erythroid compartment. And so, based on this platform, we standardized the panel, which might be useful for MDS diagnosis and maybe for prognostication. I will do it a little bit about that. So coming back to the diagnostics based on the flow cytometry concept. And if you look at it in a flow pattern, that means the amount of granulation of the cells. For instance, the granulocytes are normally granulated. If a patient with an MDS has a hypogranularity, that means that the site scatter is, for instance, down. Here you see, based on the 45 expression, the myeloblast, of the myeloprogenitor cells, the B-cell progenitors, the lymphocytes, and the monocytes, and it is then a flow cytometric plot. And what came out already in the early 2000s and later validated by the European Leukemia Net, that changes in the site scatter, the percentage of myeloprogenitor cells, but also the percentage of B-cell progenitor cells within the 34 compartment, as well as the common leukocyte antigen CD45 expression, identify MDS from non-clonal diseases. And mainly the progenitor B-cell compartment, as is said here, these are the total CD34 cells. The absence of B-cell progenitor cells in MDS patients is a really very important hallmark of the disease, which is to some extent also related to age. And also what is very elegant in this method is that the 45 expression is always related to internal controls of the normal, not clonally involved lymphocyte population. And to give you some examples of this method, the so-called Ogata score in a normal bone marrow, you see, for instance, in this plot, the 34 versus the CD45 parameter, and then the 45 dim 34 positive cells are the progenitor cells, and this accounts 1% of the total nucleated cell population. That's normal. And also here you see in the expression of the 34 positive cells with a slightly dim 45 and a low site scatter, that here the progenitor B cells came up, reflected also by the co-expression of CD19 in this plot. So you can easily enumerate all these cells in the progenitor cell compartment. Here you see the site scatter of the granulocytes related to the constant normal site scatter of the lymphocytes, the specific ratio, as well as the 45 expression on myeloprogenitor cells versus the very well constant 45 expression on lymphocytes. So you can amount for a ratio. And in this example, there are no abnormalities, although a cut-off level of 5% of normal progenitor cells is normal in bone marrow, and this is just below 5%. That might be aberrant, but that are very low marges. But in the specific case of MDS, you see that in the same way of a standardized analysis, the 34 positive population is not expanded, 1.5%, but there is a total absence of progenitor B cells, no CD9, 19 expression, a dim 45 and a very low site scatter. There is a change, a left shift to the site scatter. That means the pink cells, the granulocytes, has a lower median expression of the site scatter, so a low expression as related to the constant lymphocyte population and the normal 45. That means that there are a lot of features which mimics or might mimic MDS. And if you then try to validate that in prospective data sets within the European Leukemia Net based on these 4 parameter analysis, it was shown that by having 0 up to 4 parameters, that if you have 2 or more parameters based on a huge amount of data, MDS versus non-clonal diseases, we came up with a score of 93% of specificity in these cases with a sensitivity of approximately 75%. Relatively low. But do remember that this erythropoiesis is not yet included in this protocol yet, but I will show you some additional data. Looking to the erythroid lineages, last years we make very much progress, and here I show you some graphs of a normal flow cytometric patterns of the erythroid lineage. The pink colored, purple colored are the myeloid progenitor cells depicted here. Then the yellow are the progenitor erythroid blood cells, and then according to the maturation to more mature erythrocytes. And all these patterns depicted here based on the expression of 117 HLA-DR or the 105 and other markers, these cells follow always the same route in a normal differentiation. From here up regulation, then down regulation, up to more mature erythrocytes. And especially this graph is very important, the glycophorin expression versus the transferrin receptor. Most immature cells, then the glycophorin expression is upregulated, and then the transferrin receptor is downregulated. Almost the same pattern in normal disease. Then you see 2 examples of green normal versus abnormal, and you can directly see here difference between normal and abnormal. For instance, the lack of 71 expression during maturation is depicted here, the so-called gap, because in normal hematopoiesis regarding the red blood cell development is an empty space, and it is filled in this plastic erythropoiesis. Also, the expansion of, for instance, progenitor erythroid cells are highly expanded in MDS patients, which you can hardly see in the normal controls. And you have to realize that all this data has to be statistically analyzed between ranges of minus or plus 2 standards definition of normal. Then you go to a statistic framework, and you can exactly then identify those aberrancies within a specific lineage. These are the so-called red blood cell score. This is the first publication some years ago who identified this based already on the European Leukemia Net activities. And what you can see here, if you look here to MDS versus normal versus MDS, the other way around, sorry, this is MDS and this is normal. And based on this analysis, you can see that in normal controls, there is a tightly regulated, very narrow expression of the transferrin receptor. And during this erythropoiesis, there's a widening of the CD71 expression. And you can then calculate that MDS versus non-clonal diseases. And by this way, you can upgrade the sensitivity in this specific cohort from 49% of a flow method based on the Ogata myeloid score together with the red blood score to up to 80-89% with a specificity of over 95%. But this is the first publication. But within the European Leukemia Net, we gathered over thousands of samples together from all different laboratories, also from Robben Island, from King's, to put into a massive analysis whether or not we perform equally in each laboratory and how can we identify those markers on this erythropoiesis. And it came out that also the peak of the CD36 expression, that's the correlation of variation, the coefficient of variation in the specific nucleated red blood cell development, the transferrin receptor, as well as the expression of the transferrin receptor, and also the amount of progenitor red blood cells were highly of interest to identify this erythropoiesis related to a lot of normal controls, including also non-clonal myeloid diseases towards specific MDS cases, including some higher risk patients. So from this model, we thought we can really now also looking not only to the myeloid progenitor cell compartment, to the maturing monocytes and granulocytes, but also looking into this erythropoiesis. And then we came up with this table. And this, I think, you have to learn by head. I take you with me. What is summarized in these slides is the translation of all aberrancies. And the diagnosis score was the 4-parameter Ogata score. That means looking to the percentage of 34, the progenitor B cells within the 34 compartment, the site scatter of the granulocytes, as well as the 45 expression on myeloid progenitor cells, all related to internal controls, below 2 or 2 or higher. But what is stated in this table is that if you have a low diagnostic score based on those 4 parameters, and you do not have aberrant myeloid progenitor cells based on lymphoid expressions, for instance, if you do not have aberrant maturation patterns, and you do not have this erythropoiesis by those 4 parameters I mentioned, then we call the patient an A by flow. That means as good as normal. No aberrances seen by flow. If you have, for instance, a Ogata score less than 2, normally it's not called MDS. But if you experience a high percentage of cells co-expressing CD7 on myeloid progenitor cells, although the total amount of those cells are only 0.5% in the bone marrow, but aberrant, then it's scored as positive. If you have, for instance, 56 expression on maturing monocytes to a high level, it's aberrant. And then you can score plus, 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 or even if only 2 pluses are positive, you can score for C. That means consider MDS in this way by doing diagnostics with flow. So by looking into this table, we now already use this for several years, and Robin Ireland and Alan also work with this table now in the lab in Oberplatzberger, also in Dresden. So this model can really make sense to look into detail in this poiesis by all these parameters. And we just validated this prospectively in a clinical trial in the HOVON 89 study. And it's just published, and it showed that there are all very well characterized and reviewed MDS cases by morphology as well as by cytogenetics, and we do the ABC model in this cohort of patients, and A means as good as normal, not fitting with MDS, and fitting MDS, consider MDS by this method, and a huge amount of data in non-clonal minor diseases versus normal controls were put into this analysis. And what you can see that we came up with a high specificity of 95% in a validated prospective clinical trial to consider MDS by this specific tool. And only we missed some cases not fitting with MDS, and it was primarily based on the fact that these patients were diagnosed as having MDS based on this megakaryopoiesis. And that was not in analysis yet. So we still do miss some patients because of lineages which are not valuable or available for flow cytometric analysis. So I think with this prospective data set, the flow cytometry approach has made a useful tool to incorporate in our diagnostic tools. But also the other way around is very important. We have analyzed the last years a lot of patients who have come to the clinic and also from our regional hospitals with cytopenia. And the normal causes of cytopenia were already excluded, like iron deficiency or vitamin deficiency or other causes of cytopenia. Then the samples came in to our clinics, and then we could confirm by routine diagnostics, approximately of the 400 patients, over 200 patients could identify easily by the microscope to having MDS by standard means or non-MDS based on the combination of cytogenetics and morphology. But we still have a huge amount of patients, 161, which in the cytomorphology and the cytogenetics were inconclusive. And all these patients get additional flow cytometry. And then, if you look carefully to this analysis, of those 171 patients, we do the flow method, and if you then translate it to our ABC model, consider MDS or not, based on the flow cytometric parameters, we could exclude that most of the patients do not have a flow cytometric pattern which might consider MDS. And in the follow-up of a median follow-up of 1.5 years, only 3 out of those 114 cases did have MDS at the end in the follow-up, mainly based on this megakaryoparesis, which could not be detected by the flow. So that means that another very small percentage of patients were considered as MDS based on flow, and in the follow-up, although a small data set, we're now running almost 600 patients, 2 out of 8 at that moment were MDS later on. That means by this method you could also exclude MDS appropriately in those patients with cytopenia not identified by routine microscopy or conventional cytogenetics. So that's the other way around, to exclude the diagnosis. And if you have a patient of 50 years or even younger who have to buy a house with cytopenic, but you can exclude the diagnosed MDS, that makes sense. So the final issue I would like to speak with regarding diagnostic is based on the work of Uwe Platzberger and Uta Ulschläger from the Dresden University, in which we try to make genetic flow cytogenetic correlates. We are working in several labs on this issue now, and together with that group we had both a training cohort and a validation cohort, and look into detail to some flow cytogenetic parameters which are highly likely or highly associated with a del5Q. I don't go into the details, but we can admit a score from those flow cytometric parameters which is associated with the presence of del5Q. But more importantly is that we have a training set, MDS, normal MDS, the other way around. This is normal, this is MDS, a high flow score, and also within a non-clonal cytopenic control group, we could see exactly the same, always a normal flow cytometric pattern, both in the validation and the training cohort, but more importantly is that we followed these patients very carefully, and upon treatment with lenalidomide, for instance, some patients get a normal cytogenetics upon treatment, and it was paralleled by a normalization of the flow cytometric pattern. And in this other case, we saw a patient with a high flow score associated with the del5Q pattern. Upon treatment, there was a complete cytogenetic remission, which was accompanied by a del5Q change flow cytometric profile, but upon relapse, we saw that flow cytometric abnormalities were early apparent, going up to the same profile. So this is a way to have a genetic flow cytometric correlation. How the last part is how to deal with prognostication. We are all aware in clinical practice of the IPSS revised model. And it states that we have now 5 groups, but still it is very important. How should we deal with the intermediate group? Is that low risk or high risk? Belongs it to the high risk group or a very low risk group regarding treatment decisions? And if you validate this in our own cohort, we envision already that in our hands the intermediate group is a little bit more like it is in high risk group. So we need additional markers to separate those, because that might have consequences for clinical decision making. And if you look then into detail to a large amount of MDS samples in our own laboratory, and you look to the so-called flow cytometric score, that means the summary of all aberrancies seen in the different compartments, then you can see already that, for instance, within refractory anemia with ring sideroblasts, so a well-defined entity within MDS, we have a rather heterogeneous flow expression. That means that there is, within a red blood cell disease of an unilineous dyserythropoiesis entity, we encounter a lot of dyspoiesis into the myelomonocytic differentiation pattern. And you might assume that maybe patients with a high flow score, although atypically a RAS or an RMCND-RS, this ring sideroblast, do behave differently as compared to a low flow score. And the Logan group was the first who showed that, although it was a small series, that within the RCMD, for instance, with a low or even a high score, you could easily separate prognostic value. For instance, these are only RCMD patients with no aberrancies based on flow, mild or even very high aberrancies. and they do clinically totally different. And in a huge data set of our own laboratory, we found the same. These are all low incidence based on the accumulation of aberrances in all lineages, mild or even no aberrances. These patients do totally different based on flow cytometric analysis, based on a standardized panel and a standardized way of analysis. And specifically in, for instance, the intermediate in the good risk group based on the IPSR cytogenetics, we could separate within this IPSR well-defined subgroup, patients are doing good, intermediate, or very bad, although all in the same IPSR subgroup. That might have consequences for clinical decision making. And although this is based on the total amount of aberrances, it might be easier for clinical practice to identify those parameters who are the most powerful. And we just published in Leukemia this analysis, and we found that looking into specific with specific parameters like scatter of the myeloprogenitor cells, like the 117 expression on the myeloprogenitor cells, or some antigens expressed on monocytes, could identify those most powerful parameters out of the total of 40 parameters. So that might diverge to focus on specific genetic phenotypic relationships. So, but we know now in the molecular era, and the Elie Pape-Manuel and Thorsten Havelach paper showed very clearly that there are top 15 genes who are most frequently mutated in MDS, low and also even in high-risk MDS. And they showed the prognostic value of this. If you combine those 14 genes who are most frequently found in MDS, together with some parameters out of the IPS revised model, like cytogenetics and some hematological parameters, you could dissect easily also prognostic different subgroups. And even alone with genetics, you could identify that. So this means that genetics could do the same as flow. And if we now compare our flow analysis on a specific IPSR low risk group, you see we can separate the same as was done by others based on the IPS or risk models with the presence or absence of some specific mutations, in this case AZH2. You dissect those with a specific risk, but in the addition of a mutation in AZH2, the curve is going to the left. But by flow, we can do the same. So the question is at the end, which technique is most informative, most standardized, which can be applied in clinical decision making. And I can say you that the flow cytometric approach is very, very well standardized, although some critical people say always flow is subjective. But that is not true, because the statistical analysis behind this analysis is very well equipped and is all based on deviations from normal, not on the interpretation of a pattern, but based on statistics, with a huge sensitivity, because we are able to see lineage infidelity markers on the myeloprogenitor cell level, although the myeloprogenitor cells are, for instance, 0.2% of the total nucleated cell population. Finally, we showed that also aberrant immunophenotypes can predict response on erythropoietin. We are all aware of the Nordic model related to the endogenous EPO level and the transfusion need, whether or not the patients respond to EPO. But what we have done here in this data set, we looked to the serum endogenous EPO level based on the similar cutoff levels based in the Nordic model, but then we add the absence or presence of abnormalities on the level of myeloprogenitor cells. And then we could easily separate those patients who respond to therapy or not. In the presence of aberrant myeloprogenitor cells, there's no chance of response on EPO. And we're now doing a prospective validation trial to whether or not this is reflecting the biology of disease, which is, I think, the case. Then also an application could be that aberrances on the stem cell level or the CD34 positive level predict response on, for instance, EPO, and is less subjective than transfusion burden. Okay, finally, how to report to the clinicians nowadays regarding flow cytometry. So we propose within the European Leukemia Net, and also King's is doing now in this way, flow cytometric analysis does not have features with looking like MDS, or it's consistent with MDS based on the parameters I showed you, or it's in between. So most important is C versus A. And we try to work on that the amount of patients having a B definition, it could be or not, is as small as possible. And I think this is a very small patient subgroup. But flow cytometry is one of the diagnostic approaches. And it should be reported in an integrated report. That means the peripheral blood, the cytology, the biopsy, the cytogenetics, molecular data in future, and now SLTB1 is already in there and of importance. But note, this megakaryoparesis is not included in the flow cytometry yet, and will not come in also, because we did an huge analysis with Alberto Ovaro in Spain, looking to this thrombopoiesis, but we could not make a very sensitive and specific approach now, looking into detail in thrombocytes. So I think it will not be happen soon. And also, if the integrated report, including the cytometry, is not diagnostic, repeat in a patient with cytopenia after 6 months. And still now, waiting on prognostic value in independent prognostic prospective studies, we will not respond yet into prognostic value, although there is a lot of prognostic information in flow. So recommendations, use flow and report in an integrated way, and that's based on the European Leukemia Net guidelines, as well as now incorporated also in the USA guidelines. Start with a small panel, the so-called 4-parameter analysis, but extend your laboratory with the integrated flow score, which also includes now this erythropoiesis, the so-called ABC score. And also it is shown, I didn't show you all data because of lack of time, but it is highly associated with transfusion node, with transfusion, with transformation to AML, as well as response to EPO. I show you data, but also I have data on the response prediction of hypermethylating agents. So there are a lot of projects within our team and together with the European Leukemia Net networks. So we are now collecting a huge database over 2,000 samples of different laboratories. Full implementation of this erythropoiesis. At the moment, we explore new, more specific parameters on this erythropoiesis. We will come out this year with a diagnostic algorithm to the new WHO recommendations. We are making correlates between del5Q, basically based on the data of Uta Oerslegel from Dresden, but also on Seattle and of the Hoven 89 studies. We are looking into monitoring MDS under therapy. We are looking on a prospective data set of the del5Q. We are looking into details on monocytes, and also we are collecting data on ICAS and other clonal diseases with undetermined potential of minor diseases. And this thrombopoiesis, that project has been stopped based on the criteria I said you. There's less specificity based on a lot of activation markers in thrombocytes if you do that in an EDTA or heparin tube. So I would like to thank you for your attention, and I would like to acknowledge my own team working on this subject for a couple of years, but also the very elegant and fruitful collaboration within the European Leukemia Net with Robin, Ireland and Alan, and with Uwe and Uta, but also with Spain, with Austria, Peter Valent, with the Greece group from Caterina, with French group, with the Italians, Luca Marcofrati and Della Porta, but also in Japan with Okate himself, with Taiwan, and with the Seattle group from Mike Logan and Denise Wells. Thank you for your attention.
That was a fantastic talk, and I enjoyed it very much. Have you got any questions? Yes, there's one in the audience.
Thank you, that's a very interesting talk. I was just wondering, in terms of planned collaboration, is there any data available at the moment to predict who would benefit from specific treatments, thinking about the high-risk patients, for example, azacitidine, based upon the initial studies?
Yeah. We published a year ago in Cytometry the first data about the amount of aberrancies before starting azacitidine. And the amount of aberrancies on the myeloprogenitus level mainly is highly correlated with response or not. And also during azacitidine treatment, we sampled every 3 months. And what we found is that sometimes with treating patients with azacitidine at 6 months, there is no change in cytopenia levels and no change in blast. But then the decision is, should we continue with azacitidine or not? And in that paper we showed that if you have still high amount of aberrancies, you never get a response anymore. But if you have a downregulation of the amount of aberrancies, the patients will have benefit from azacitidine treatment. So although the series was only 50 patients, we are now trying to get more patients out of that because it should be validated. It might be fruitful to use this parameter serially during treatment, whether or not to decide that hypermethylating agents or others may benefit for the patients. So that is the application we would like to do. Really a clinical translation. Yes.
Catherine?
Thanks, Arjan. That was great talk. I've got 2 questions actually. The first one, do you have any data incorporating molecular
Yes.
cytometry in the non-diagnostic or in the diagnostic?
Yes, I hope you will be at ASH. And that Saturday afternoon, I had the opportunity to have an oral presentation. And within the HOVON 89 study, we have done all molecular analysis and flow together with clinical outcome in the non-del5Q lens study of the HOVON 89. And then I show you the correlates. Yes, so there is a correlation. And the mainly issue is that can we predict non-del5Q len in a subgroup of patients, because we know from the Santini paper, we know from the Alan List paper that almost 1/3 of the patients may benefit from lenalidomide in non-del5Q. It's the same was true for the HOVON 89 study, which studied the same question. We have a response of 34% in that particular group, but also a lot of toxicities. And now we are trying to get out, based on flow, together with molecular mutations and the correlates, how we can identify those patients who might benefit from a rather toxic drug in non-del5Q. Yes?
The other question is, I think our main issue from the MDS panels is the size of them and the time it takes for analysis. We get a massive number of cases for investigation of cytopenia. I was just wondering if you thought in the future there could potentially be a stepwise approach,
Yes.
as in an
Yes.
initial smaller panel and then a larger panel.
Exactly, and that's exactly what the major task should be, is now define a diagnostic algorithm in which we can use from a practical point of view, and also not do every analysis on the cytopenic patients. And how we are performing now is that we have an original function, like also Robin's lab is it came in cytopenia, all things are ruled out, and then we focus on the combination of additional molecular as well as flow cytometric analysis, and that should be in an algorithm. Otherwise, it's maybe too costly and it cannot attribute to a final diagnostics.